Hello, salam sejahtera. So today we are going to discuss about the arrhythmia treatments algorithms in this ALS course. This is an updated version, so you will get the latest update of the ALS algorithm. So these are the objectives. You are expected able to manage the pulseless arrest, the bradyarrhythmia and the tachyarrhythmia. So when we say cardiac arrest, what we meant are VF, VT, PA, and asystole. An example, let's say a patient come to you with unresponsiveness. So you initiate BLS. How you initiate BLS? Yes, your DRS ABCD. You assess the danger, you tap the patient's shoulder. Hello, hello, are you okay? If patient is not responding, you shout for help, you open the airway, you scan for breathing. If there's no breathing, it equals to cardiac arrest and you start CPR, chest compression. Then when the helps come, so you attach the cardiac monitor and you ask your assistant who is doing CPR to stop because you want to analyze the rhythm. Let's say now the rhythm is asystole. So you continue CPR, you do everything within the 2 minutes time. When we say everything, we meant the IV access and you give the adrenaline every 3 to 5 minutes. But I prefer you give a standard order 1 milligram of adrenaline every 3 minutes. And then you emphasize on the high quality CPR for 2 minutes. Then when 2 minutes up, you stop chest compression, you feel for the pulse, analyze the rhythm, and the rhythm still show asystole. You continue your CPR and you treat the reversible causes. The question is when you should intubate the patient. So in non-shockable, meaning PA or asystole, you intubate the patient as early as possible. Meaning once you establish the diagnosis of asystole, you ready the IV access, you give adrenaline and at the same time you intubate the patient. Then after the subsequent 2 minutes, the second 2 minutes, you continue the CPR and you treat the reversible causes. We are going to discuss the reversible causes later. And another example, let's say again you have a patient, unresponsive patient, and was brought to you, so you initiate your BLS again, you activate your DRS ABCD, danger, you check for responsiveness, if patient is not responsive, you shout for help, head tilt chin lift, open the airway, scan for breathing. If there's no breathing, you start chest compression. So once the help come, you attach the cardiac monitor, and let's say the cardiac monitor shows VF, immediately you resume chest compression while preparing for the shock. Once you are ready for shock, then you give the first shock. It depends whether you are using monophasic or biphasic. Then you said I'm clear, you clear, everybody clear, shock given. After the first shock, you continue with chest compression, high quality CPR. And during that time, you don't have to intubate the patient, you just concentrate on the high quality CPR. What you may do is you insert the IV line and you draw bloods for investigation. Then 2 minutes up, you stop chest compression, you analyze the rhythm still VF, immediately you give the second shock. I'm clear, you clear, everybody clear. shock given, continue CPR. Okay, so during that time, after you give the second shock, you give adrenaline 1 milligram every 3 to 5 minutes. Again, standard order is 1 milligram every 3 minutes. And if not, your assistant will get confused. And during this time, you intubate the patient. And again, after that, you emphasize on the high quality CPR. Then the 2 minutes up, you stop chest compression, analyze the rhythm, feel for the pulse, rhythm stills, VF. You prepare for the third shock. I'm clear, you clear, everybody clear. Shock given, continue CPR. And you continue your adrenaline, and at this moment, you give your amiodarone. The dosage of amiodarone is 300 milligram slow bolus. How slow is slow? So basically you give within 1 to 2 minutes, or ideally it should complete before the 2 minutes time up. Okay, so at this moment you look for the reversible causes, the H and T's: hydrogen ion hypoxia, hypothermia, hypovolemia, hyperkalemia, hypoglycemia, cardiac tamponade, tension pneumothorax. Pulmonary thrombosis means PE, coronary thrombosis means acute coronary syndrome, and you ask the family members whether the patient have taken any drugs. And next, when the 2 minutes up, you analyze the rhythm. If patient still having VF, you give the fourth shock. I'm clear, you clear, everybody clear. Shock given, continue CPR, then you give your second dose of amiodarone, which is 100 milligram, slow bolus within 1 to 2 minutes. So you must always ensure that your assistant giving high quality CPR. High quality CPR is push hard at least 5 cm depth and fast. The rate is between 100 to 120 per minute, and allow complete chest recoil. Okay, minimize interruption in compression, avoid excessive ventilation, rotate compressor every 2 minutes. If patient is not intubated yet, the ratio of chest compression and ventilation is 30 to 2. Okay, you may use Untitled CO2 to look at the quality of the CPR. Okay, so after you intubate the patients, you must confirm placement, and you may use the waveform capnograph to monitor your AT tube placement. And once your AT tube in place, give one breath every 6 seconds with continuous chest compression. Again, the rate should be between 100 to 120 per minute, and the depth is between 5 to 6 cm. And again, always look for the reversible causes. The pitfalls in ALS mega code is the participant always asks about the blood result. I suggest you start with asking whether is the IV drip running, any bleeding, any signs of dehydration, and you ask your assistant whether there is hypoxia, ask whether the oxygen is connected, how's the bagging, any resistance in bagging, is any chest rise, and only after that you ask for the result of VBG, ABG to look for the acidosis, and you ask for BUS result or renal profile result to particularly look at the hyper or hypokalemia. And of course, you may check the temperature to rule out hypothermia. and then you need to diagnose tension pneumothorax clinically. Cardiac tamponade backstriate might not be helpful, but you may ask for ultrasound to look at, for cardiac tamponade, and the toxins is the history from the witnesses. After there is return of spontaneous circulation, and then you may want to keep the patient hypothermic for 12 to 24 hours and maintain strict glucose control between 4 to 6 millimole per liter and continuous clinical signs monitoring. Okay, now we go to bradycardia and tachycardia. In bradycardia, we need to assess the patient clinically. So by definition, heart rate less than 60 is bradycardia. However, if the heart rate is less than 50, they might be bradyarrhythmia. So you assess clinically, and you give oxygen first, and you attach the cardiac monitor, establish IV access, and you perform the 12-lead ECG. The most important thing when you have patient with bradycardia, you need to assess the hemodynamic stability. You can start from head, where the patient have altered mental status, ask where is he now, is it what time is it now, morning, afternoon. You look for altered mental status, and then you go from the head, you go to the chest, ask whether he's having chest pain, whether he's having acute shortness of breath, indicates acute heart failure. And next, you check the BP, whether there's hypotension, and you feel the peripheries, whether it's cold. Any evidence of hemodynamic instability, you need to treat. And the first line treatment is atropine 0.5 milligram, and you can give it up to 3 milligram. It fails, then you can give dopamine infusion or adrenaline infusion, and in some patients, transcutaneous pacing might be helpful. Same thing when you assess for tachyarrhythmia. Again, heart rate of more than 90 is tachycardia, but if the heart rate is more than 150, you should not think only about sinus tachycardia, but you need to think about tachyarrhythmia. Regardless of the rhythm, you need to assess whether the patient is stable or unstable. The same question as when you assess for bradycardia. You ask for level of consciousness, time, place, person. You ask about that, whether there is any altered mental problem. Then you go downwards and ask for chest pain, shortness of breath, and then you measure the blood pressure, and then you assess the peripheries to look for clinical shock. If stable, then you may treat with drugs, example SVT, and you treat with adenosine first line. But if patient have contraindication to adenosine, such as he has asthma, and then you need to go with verapamil. Okay. In patient with fast AF, if patient having concomitant heart failure, digoxin might help. If not, again you may use verapamil. Okay. If patient have allergic to verapamil or any contraindication to verapamil, you may use amiodarone. However, in the presence of any evidence of instability, you need to synchronize cardiovert the patient. And don't forget to get the consent first, followed by sedation and analgesia before you cardiovert the patient. We're going to go into that more details during the skill station. So these are the American Heart Association 2015 guidelines recommendations. So during CPR, you are allowed to give high concentration of CPR. However, post CPR, you need to titrate the FiO2 with the aim of FiO2 between 94 to 100. This is because recently they noticed that hyperoxia, meaning high concentration of oxygen, is not good for the heart itself. There is no changes in the dosage of the adrenaline. Still we use 1 milligram every 3 to 5 minutes. So how fast you need to give the adrenaline for non-shockable rhythms, means PEA or asystole, it's reasonable to administer adrenaline as soon as possible. But for shockable rhythm, you should defibrillate the patient first before you give the adrenaline. Shock is more important than adrenaline in shockable rhythm. Don't forget you may use amiodarone for VF and pulseless VT that is unresponsive to CPR, and other choice is lidocaine as alternative to amiodarone. Remember, after the third shock, in patient with pulseless VT or VF, we give amiodarone bolus 300 milligram, 1 to 2 minutes, and after the fourth shock, we give amiodarone 150 milligram bolus 1 to 2 minutes. The important aspect for cardiac resuscitation is basically high quality CPR. So if patient have difficulty IV access, then it must not stop your chest compression. Your chest compression must be continued. You should not delay the chest compression and the defibrillation because you can't get IV access. So they also mention about focused echocardiographic evaluation in life support, meaning if there's a qualified sonographer and the use of ultrasound does not interfere with the standard cardiac arrest treatment protocol, then ultrasound may be considered as an adjunct to standard patient evaluation. So during the pulse check, rhythm check, you can put the cardiac probe either on the look for 4 chambers view or short axis, or I prefer the probe to be on the subxiphoid or subcostal area. But remember, you should not interfere. I prefer the subxiphoid or subcostal view because it will not interfere with the chest compression. Basically, post return of spontaneous escalation, the take-home message is no fever, please, and there is belief that controlling of the body temperature at the 36 degrees Celsius would have some clinical benefit. So, in summary, effective ALS begin with high quality CPR, uninterrupted high quality chest compression, improve outcome, early recognition and treatment of arrhythmia give the best chance of survival, search for treatable causes of cardiac arrest, post-resuscitation period is important, know your algorithms well. Thank you very much. Have a nice day.